Well, good evening, everyone, and welcome to the Brian Crombie Radio Hour on Saga 960 AM. Well, I've got a really interesting gentleman to introduce you to tonight, and I apologize in advance. I'm not sure if I'm going to pronounce his name right. He's Dr. Eleftherios Diamandis. Is that okay?
You got it right, Brian.
Excellent. He's a laboratory and pathobiology biochemist and cancer specialist at Mount Sinai Health System, and he's working on and has been proposing, get this, a self-infecting clinical trial to build immunity to COVID-19. A self-infecting clinical trial to build immunity to COVID-19. So, Dr. Eleftherios, please tell us what you're proposing.
Well, actually, it's not self-inflicting. I will explain what we are proposing, Brian. As you know, COVID-19 is with us now for a few months, and we cannot get rid of it. It's here. So in order to battle COVID-19, people have implemented the so-called mitigation measures that everybody, all your viewers know about, which means avoid the virus. Don't get close to people who have the virus. Avoid, avoid, avoid. So this is a short-term solution because we cannot avoid each other for too long, as you know very well. So this is an interim solution which helps people not get infected, stay out of the hospital, and the hospitals are not overwhelmed, as it happened in other countries like Italy and so on. So this is the one solution. But this solution is not going to go for a long time. We have to find a different solution. And obviously, what everybody is talking about, the different solution is a vaccine.
Yes.
But I believe it's a mistake to put all our eggs in one basket and say vaccine, 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 because the vaccine may take time or the vaccine may not even succeed. As you probably know, we are trying to develop a vaccine for HIV for the last 30 years unsuccessfully.
Sorry, let me interrupt for a second. You're using the lack of our ability to develop a vaccine for HIV for 30 years as sort of the suggestion that it's going to take a long time.
No, the COVID-19 vaccine may take at least a year, 2 years, 3 years. So the big question is, what are we going to do in the interim? Well, one of them is isolation. I don't know if you can isolate yourself or your viewers will isolate themselves for another 3 months, 4 months, 6 months, because they're getting tired of it. So we are proposing an interim alternative solution just in case the vaccine is delayed or is not as successful. What is the alternative solution? Well, there are two alternative solutions. One of them is the solution that Sweden went through, and they said, let the virus go around, infect whoever, kill whoever, and then everybody will get immunity and it will be okay.
So building up herd immunity over time naturally.
Yes, that's right. The proposal that we are doing is a variation of this, and we believe it's a much safer variation. We say this, we are not saying self-inflicted infection. We are saying those who are selected for infection to produce immunity go to a hospital, and the hospital will have a special unit where they will infect the person with a virus and then monitor very, very closely the person in the hospital until the 2-3 weeks go by. And we believe, I don't know what you believe, that this kind of approach, instead of letting the people get the infection naturally, to go into a hospital and do it like a procedure under medical supervision. And we believe that the result will be much better if the people who are getting the immunization have immediate care. If they need ICU, they will have it there. If they need intubation, they will have it there. So it's an alternative solution whereby the immunization with the live virus will happen in a hospital setting under continuous supervision.
And what's the response of the clinical regulatory people to your proposal?
As you know, this is not a new idea because self-infection with other viruses like measles and chickenpox was happening 50 or 60 years ago before the modern vaccines were developed. So people
I've heard about people that had chickenpox parties, for an example, where they invite all the neighborhood kids over and get them all infected.
Yes, this is a variation with the important caveat that the infection will happen in a hospital setting under continuous medical supervision. So a lot of people are skeptical because they believe, and I think it's correct, that some people through this process may actually lose their life. There is about 1 in 1,000 chance of somebody dying from the COVID infection, even in a hospital, because we know that medical doctors and nurses have lost their lives to this. So it's not absolutely safe, but we hope that it can become safer with additional measures like modifying drugs like the newly developed remdesivir. Heparin is now coming into the arena. So we believe that with improvements, modifying drugs, that they can reduce the intensity of the disease, maybe the mortality of people who select to be infected under a medical supervision will be close to zero. And this has to be shown. So most of the responses you are getting are negative from the ethical point of view. They say you're using human beings as guinea pigs to try this. And we appreciate that. Obviously, if we ever do it as a clinical trial, we have to obtain ethics approval to do it. But you know what was surprising? When our idea was published in the National Post, I got immediate responses from many volunteers who wanted to actually join.
Yep.
The reason they want to join, they are sick and tired with the mitigation measures. They want to live their lives, and they say, I better get the immunization under supervision and get on with it.
Well, fascinating. We're chatting tonight with a clinical cancer biochemist and cancer specialist, Dr. Eleftholios Diamandis from Mount Sinai Health Systems, about a self-inflicting clinical trial to solve COVID-19. We're going to take a break for messages and get right back to you. Stay with us. Well, welcome back, everyone, to the Brian Crombie Radio Hour on Saga 960. A fascinating conversation tonight with Dr. Eleftholios Diamandis, who's a laboratory and pathobiology biochemist and cancer specialist at the Mount Sinai Health System. And he has proposed a self-infecting clinical trial to build up immunity to COVID-19. And Doctor, maybe I could ask you a couple more questions about that. So the people that you would propose joining your clinical trial, would they be a random sample of the population, or would they be people that are low at risk, younger people, people without respiratory problems, immunity problems, etc.?
No, these will be healthy people, provenly healthy people after medical examinations of ages between 20 and 44, because it has been shown unequivocally that younger and healthy people are relatively resistant to the virus, and the mortality of these people from the infection is very, very low. So we want to select, if we have this privilege, people who are happy individuals, key individuals, medical doctors, nurses, drivers, cashiers, firefighters. These are people who are getting involved with a lot of other people, and we want to immunize them so that they do not propagate the infection. So this is going to be for a very selected group of individuals. And the theory says that if an enough number of these kind of individuals are immunized to about 60% of the whole population, then the older and most vulnerable people of the society will be protected as well, because many people within the so-called herd will be immunized already.
So, you know,
People
I
who are
think
not immunized will get the benefit by the other people who are around them will be immunized.
yeah, and so it probably makes a lot of sense because this is effectively, you're effectively vaccinating people, but with the act of virus, the actual virus, rather than a small little sample of the virus in a vaccine.
You got it right.
But obviously, to get the actual virus, it's a lot more potent than the vaccine. The vaccine is typically a very small, non-lethal amount of the vaccine that's in a.
Yes, the vaccine usually doesn't involve live virus. It only involves the proteins of the virus, but sometimes only the proteins of the virus do not produce good immunity. So the live virus is likely to produce better immunity, but obviously it's more dangerous.
So, you know, I have seen a couple of reports of people in that age group of 20 to 44, healthy, that have ended up not only getting infected, but having severe complications, if not mortality. And so it seems like this virus, for some reason, strangely can, you know, impact different people in a very different way. How do you know the people, the right people to choose to bring into your clinical trial?
We don't know, but I agree with you that there are reports, rare reports, that very young, even children, have died from the virus. A very small proportion. 1 out of 1,000 and 1 in 10,000 younger people who die from the infection. But it's also very likely that these people had unrecognized medical conditions that they didn't know about. They are probably diabetic, or they had some other condition that aggravated the viral infection. So when we say a younger person died from the virus, it doesn't mean that it was truly a healthy person. They may have an underlying condition that made their disease worse.
So you would exclude from this clinical trial anyone that's diabetic, anyone that's got immunity issues, etc.?
Yes, we will do a very careful selection of our volunteers. And actually now there are so-called artificial intelligence software in which you can put all the information you know about the volunteer, and the artificial intelligence software will tell you if they are good candidates for such a trial or not.
Now,
so it will be very stringent.
To run such a clinical trial, if it was a drug, you would need to have Health Canada approval. Do you need Mount Sinai ethics approval as well as Health Canada approval to run such a trial?
Oh, without saying that, with most of the discussion around this approach will be about ethics. Some ethicists have already judged on this proposal, and they said if the people who are going to participate in the trial volunteer and they sign an informed consent, then the trial could be claimed as being ethical. And this approach is no different from somebody like you or me who wants to donate a kidney. As you know, donating a kidney carries a risk of dying of the donor of about 1 in 1,000. And it's considered ethical if somebody says, I want to give my kidney even if I have 1 in 1,000 risk of dying from the donation.
And so you've been turned down so far?
No, we haven't. We are applying to the province with a deadline in 3 days for a grant that will give us the money to start this trial. Obviously, there will be a lot of preparatory issues, ethical issues, microbiological issues. We have to isolate the virus, purify the virus, titrate the virus, because one of the caveats of our procedure is to give the smaller dose of the virus that produces immunity but not side effects. So there is background work to be done, and we are applying for funding as we speak.
And is this an opportunity that you could turn to a profit, or is this something that the federal government or the provincial government would have to fund? I can imagine if you actually perfect this smaller version of the virus, is that something that you can patent and effectively market as a
maybe, but this is our totally secondary, tertiary concern. Our concern is that if we can see that we contribute something to the problem, and I'm not sure if you know it, your viewers should know it because it's their money, the Canadian Institutes for Health Research, as well as the provincial government, and just about every other granting agency have thrown a lot of money into research regarding COVID-19.
Yeah.
And now researchers like me who were doing cancer up until 2 months ago, we gave up on this, and hundreds of thousands of researchers have changed their subjects from whatever they used to do to the COVID-19, just in case we make very rapid progress. And this is a worldwide phenomenon, not just a Canadian phenomenon.
I completely understand, but you're going to have monies to fund the actual trial, hospitals, doctors, etc. How do you fund that? That would be through grants as well?
Yeah, through grants, through provincial grants. We applied for a provincial grant at the tune of over 5 million to do a trial of about 500 volunteers, and we are now applying to CHR for significant funding as well.
Well, that's fascinating. So maybe ask a couple of questions about the disease, if I could, the infection. So it seems that it's a lot more fatal in men than women. Any idea why?
There are many unknowns with this disease, with differences in gender. There are differences in socioeconomic status. As you know, minority groups are much more vulnerable and so on. The reasons are unknown. There may be a genetic component to it, but a lot more needs to be learned about this new virus. So we don't have all the answers yet.
So you mentioned socioeconomic. I understand that African Canadians, African Americans have had a far higher percentage. Is that because of something genetic, or is that because of their socioeconomic status? There may be poor diet, there may be obesity, there may be diabetes, and so therefore it is not because of anything about the race or the genetics, but it's about lifestyle and diabetes.
The answer is all of the above. The role of genetics has not been delineated yet. I'm not aware of any genetic susceptibility genes that they have been found in minority groups as yet, but maybe they will come about, or the reasons may be the ones that you mentioned.
So I'm not sure if you're familiar with hypertension, but I understand hypertension also has a greater propensity within African Canadians or African Americans.
Yes.
That again is caused by diet and lifestyle and obesity and diabetes, not necessarily anything about genetics. Is that correct?
Yes, it would be an aggregate factor. Yes, it's very correct what you're saying.
So you said minority groups. Are there other minority groups that are overly impacted by COVID-19?
The one with low socioeconomic status, and one of the reasons, as you said, is that these people are not usually seeking immediate medical attention, and they stay at home, and until they go to the hospital, it's too late. So maybe this is a major factor, I guess. But we still are learning a lot about this new virus and the susceptibility, the genetics, and so on.
So I'm intrigued by the fact that young people have such a low mortality.
Low mortality, yes.
The Spanish flu, 1918, 1919, 1920, actually had a far higher mortality rate for young people. Why did the Spanish flu have a higher mortality for young people, and then this COVID-19 a far higher mortality for people over the age of 65 or 80?
I wish I knew. The game is played. The game that we are seeing in sick patients is a war between the virus and the immune system. Now, the immune system that we have is probably the most sophisticated system that we have in our body, because it's a surveillance. It's like the policeman of the body, and they go around looking for viruses to destroy them. Now, why the younger people in this case have a much better resistance is likely because their immune system is younger and more amenable to fighting. But as you have said correctly, the Spanish flu was the reverse, and it's difficult to explain.
We're chatting about clinical trials. Self-inflicted infected clinical trials for COVID-19 tonight. And we're going to take a break for messages and be right back with you. Stay with us. Welcome back to the Brian Crombie Radio Hour on Saga 960 AM. We're chatting tonight with Dr. Diamandis, who's a laboratory and pathobiology biochemist and cancer specialist at Mount Sinai Health System. And he has proposed to the provincial and federal governments a self-infecting clinical trial to build immunity to COVID-19. And we've chatted a little bit about it so far, and we're going to continue our conversation. Doctor, I had Tony Clement, former Minister of Health, on my show, and he was saying that we learned something from SARS, but not enough from SARS, and we forgot a bunch of the things that we learned from SARS. Maybe I could ask you a couple questions about that. Why is this so much more lethal than SARS?
Well, the SARS and the COVID are members of the same family. The difference, the major difference, I think, is that the COVID-19 virus is much, much, much more infective than SARS, although SARS is more lethal. So with SARS, when the SARS came, and I was here when it came, the measures of isolation, taking the people who had SARS, isolated them from other people so that they don't transmit, was very successful because very quickly the people who had SARS were isolated, there were no further infections. This virus is extremely infective. And if you can imagine that this virus started from Wuhan, China 2 months ago, 3 months ago, and now it's in every country of the world, it's in every city of the world. It got into the White House, it got into the Prime Minister's of England's office, it infected a lot of people, politicians, athletes, and the like. You can see the difference. This virus is very, very infective. And another item that is very important is that at the initial stages of the infection, the virus remains asymptomatic. So people don't know that they have it, and they spread it.
And is that, I apologize for interrupting, is that one of the big differences with SARS, because SARS was not infectious until you had symptoms?
Yes, exactly. So now the COVID-19 can actually spread without the people who is spreading knows about it because they don't have symptoms. So this is why there are millions and millions of people who got infected. And this is very difficult to control because the isolation measures do not really work very well because of the wide spread. So the only way to really go after the COVID-19 is with a vaccine or with some other measure that they actually combat the virus or make the people, the general population, not vulnerable to infection, make them immune. So that's the big difference. SARS was relatively easy because it didn't spread as much. And this one is relatively extremely difficult because it spreads so quickly and it infects millions of people.
What do you think about the Swedish experiment of just sort of letting it run wild?
It's one of the approaches. Eventually, in order to get rid of the COVID-19, as I said earlier, we either have to isolate ourselves for years, or we have to let it through a vaccine or some other measure and do it. The Swedish experiment was interesting, but they paid the price. As you know, they have a lot of dead people, especially of the older ages. So if we let this COVID-19 go around freely, I think we will see millions of people, especially in the ages, over the age of 80, losing their lives. And I don't sponsor that.
Lots of people think that the infection is going to naturally die down during the summer, during the hot months. Do you agree with that?
Well, I have no idea. I wish I knew the answer, but the data show that it's not doing it.
The data, because it's still in Australia, New Zealand, etc.?
Yes, and in some cases in the United States, actually the number of infections are going up. In other states it's going down, but in some states it's actually going up. So I don't see it slowing down.
Why would it go down in the summertime? You know, you think about a typical influenza, it does die out in the summertime. What causes it? Is it heat that would typically cause it?
Well, it was speculated early in February, March by Trump that this thing will disappear in March, right?
Yep.
And it turned out because of the weather conditions. But it seems like the weather conditions didn't affect the virus very much.
In 1918, 1919, the second wave in the fall, because we had a very similar kind of situation as now, where you know, there was a first wave in the spring, and then it died out in the summertime, and then the second wave came, was actually more lethal than the first wave. Are you worried about that?
Yes, I'm worried because the virus is mutating over time. There are now a lot of reports in the literature which show that this COVID-19 is mutating. And there are some strains which have mutated, and they're probably already, these strains may become resistant to the vaccine that we are trying to develop. So I'm worried very much that this thing may come up with a strain that is even more lethal. And if we don't have a vaccine to combat it, I think we're going to be in big trouble. I don't want to create panic with your audience, but it seems to me that the solution to this COVID-19 is not going to be a simple one.
But you know, even with a flu vaccine, don't we get a flu vaccine that contains several different variations, so
Right.
that different strains of influenza are combated? So can't we think about the vaccine for COVID-19 potentially having a couple of different strains in it?
Yes, but we, as we say in science, we have to see it first. We can speculate whatever we want, but we have to see it first. One of the biggest questions in the COVID-19 discussion is if the infection gives you long-lasting immunity. This is a critical question because if the immunity is weak and people can get reinfected or the immunity lasts only for a few months, I think the troubles with COVID-19 will multiply because we won't have a robust battle system against it. I don't want to sound pessimistic, but there are dangers that the immunity that we get from the infection, even if it's a natural infection, may not last long. And if it doesn't last long, the vaccine may not last long, and the victory over COVID-19 may be a lot more difficult than we think.
Don't those two risks that you've identified also have an impact on your trial and on self-inflicted infections? That if an infection doesn't last long, and or being infected doesn't make you immune to a mutated virus for a vaccine, that would have the same impact on people that go through your trial, would it not?
Yes, these are two very big risks for which we don't know the answer. As you probably know, it was reported recently that some people in South Korea who got infected with COVID-19, they were found after a few months to got reinfected, which means that the immunity was no good. But fortunately, further research has shown that these people actually, they were not reinfected, but the test that was used to detect COVID-19 was detecting that virus. So that's a great hope that we haven't seen too many people getting reinfected, which means that the immunity is probably okay for at least 9 to 12 months.
So sorry, let me interrupt. So what you're saying is these people that got the test the second time showed that they had the virus, but it was a dead virus rather than a virus.
Yes.
When you have a dead virus, it's still in your system, but you cannot infect people, obviously.
Well, the test that detects the virus is based on the detection of the nucleic acid. And these researchers found that the people who supposedly got reinfected, they had pieces of the viral RNA from the previous infection. It was the dead virus. So that's very, very good, very supportive result.
So I had thought the only way that you could test after the effect was with one of these antibody tests. What you're saying is the antibody test will be able to tell you whether you got antibodies in your body from having the virus previously. But in addition, the actual COVID-19 test might show that you've got some dead virus still in your lungs?
Yes, there are two tests that we are using. One is we're testing for the RNA of the virus, the genetic material. And this test is detecting live virus and dead virus, as we know now. The other test is called the antibody test, in which it has usefulness 2 to 3 weeks after the infection. When we develop antibodies, we can test for the antibodies in the blood and determine if this person was infected by the virus earlier, a month earlier. These antibody tests are going to be very useful, and we are currently working at Mount Sinai Hospital, University Health Network, and believe me, every hospital in the world is working towards implementing the antibody, the COVID-19 antibody test, because these tests will be invaluable in telling us how many people in the society have actually got infected with the virus.
And didn't know about it.
We do not know because we haven't tested everybody. We currently do not know in some cities, the infectivity rate is claimed to be 20%, like in New York. And obviously in some other cities it's much lower, at around 1% or lower. So the testing is coming up for the antibodies. The testing for the antigen is a standard procedure that we do now every day to see if somebody has the infection or not.
Now, where is that antibody test? Can you get it in Canada yet?
Not as yet, but over the next 2 to 3 weeks, it will be implemented in all major hospitals. We are now testing reagents that they have been produced, and within the next 2 to 3 weeks, it will become available for clinical use.
Did we ever develop a vaccine to SARS?
Me, no, never worked with SARS.
No, but did we generally, the world, was there a vaccine created for SARS?
I'm not aware of any vaccine for SARS, and as I said, the reason we don't need a vaccine is that the so-called isolation measures, because of the lower infectivity, work very well. And you can block the virus by not letting the virus getting into other people through isolation.
So did SARS just go away?
Yeah, well, the people who have the SARS infection will eventually become well, and they will not infect other people, which means that the SARS virus is gone. But as I said, this is not the same with COVID-19 because of the high infectivity. It will be very difficult to isolate millions of people for too long to get rid of the virus. It's unlikely that this virus will disappear. It will stay around in the community.
So I asked you this question earlier, and I don't think you answered it. Let me ask you again if I could. You answered about young versus old. But what about male versus female? Because the male mortality rate is twice what the female mortality rate is. Any idea why?
I have no idea why, and I'm not sure if too many people know why, but eventually the answer will come. I don't know.
Okay. Are there any other strange things? We talked about age. We talked about sex. We talked about race. We talked about socioeconomic differences.
Yes.
We talked about immunity and prior conditions. Any other interesting thing? You know, like in SARS, for an example, they were thinking that it could travel up and down pipes in buildings. Are there any other interesting things about this disease that make you ponder?
I'm not aware of things that we haven't mentioned already, no.
Well, it's absolutely fascinating, and I really think that the work you're doing is very critically important. You know, you think about some of these students that, you know, were frolicking on the Florida beaches and some of the reactions, and some people have said it was terrible, but you know, some of it is understandable. Their life has been closed down, their opportunities have been severely stymied, and the chance of them actually having anything bad happen from the disease, other than being infected and having maybe a bad cold, is very low, other than if they infect other people. And so therefore, I can understand this idea of trying to get infected early, becoming immune, and then getting on with the rest of your life. It may not be a great strategy, but there's certainly some logic to it. And you just got to make sure that during that time period, you don't go close to anyone that's got a vulnerability.
Yes, I do that. By the end of the show, I will persuade you to become a volunteer in our program and come to the hospital and get immunized with the virus.
Well, I may be a little bit too old or unhealthy for your sample, but I could volunteer one of my sons who's actually really eager to get infected and get on with the rest of his life.
Well, Brian, to me, you look like a guy between the age of 20 and 44, so that would be okay.
That's very kind of you. We're going to take a break after that compliment and come back to you in just a minute with some concluding comments from the doctor. Stay with us.
Yes.
Well, this has been a fascinating evening chatting with a doctor that works at Mount Sinai. He was a cancer specialist, and he's changed his focus to COVID-19. And he's got a proposal in front of the ethics boards and in front of Health Canada to do a clinical trial with healthy volunteers that get inflicted with COVID-19. And the hopes that then they will develop immunity, that they'll be kept in a healthy setting with doctors and proper care, and then they'll be able to go back to their everyday life. We'll be able to increase the immunity within the population, and because of that, we will have less transmission of the virus in society. And so I think it's a very interesting proposal, and I wish him well with his ethics board and Health Canada review. And I'm glad you're going and having to get that ethics board, because it is an issue. There's no question about that. During the break, Doctor, you were saying that you think that there's other issues. And I've had it described to me this way, that the first wave of COVID-19 is the health wave. And the second wave is the economic wave, the economic hit. But the third wave, which is just as important and may have more longer lasting impact, is the mental health issue. What do you think about that?
Well, I think it's a very important issue. Now there are reports in the literature describing much increased incidence of anxiety and depression among people. And this is quite understandable, because having somebody living in a room for months like a prisoner is not the same as going out and having fun and so on. So it has been documented now that the rates of anxiety and depression because of the COVID have gone up dramatically over the last month. And there is also another item, Brian, which I call collateral damage. A lot of people are calling us now and they say, I am a cancer patient, I have an emergency, and I want to go to the hospital. And there are two issues about this one. First, the hospitals are overwhelmed and they don't pay the regular attention that they used to pay to other diseases, as dangerous as COVID or more dangerous like cancer. And this is a very serious thing. It has also been reported that people who get heart attacks, I'm not sure if you have heard this, the number of heart attacks that appear to the hospital has been decreasing dramatically. And this is because people who have heart attacks, they don't go to the hospital because they are afraid of contracting the virus. So there's a lot of other people who are sick, not from COVID, but from chronic diseases, renal failure, heart failure, and so on, cancer, who are not getting the treatment that they used to get because of the system is overwhelmed, or because the doctors are too busy, or their clinics are closed. So I think this is another big price to pay for people who are older and they have pre-existing conditions, that the COVID has aggravated their condition through inferior medical care, unfortunately.
Well, and not only inferior medical care, but isolation. That
yes.
Some of the things that were keeping them alive were visits with loved ones and entertainment and singing songs and all that social interaction has been taken away from them. I've had mental health experts tell me that if you are depressed and alone, you might kill yourself. If you're depressed and you have friends, that you'll survive. And I've had people that have talked to me about dementia and Alzheimer's, and they've said the best antidote to dementia and Alzheimer's is social interaction and being challenged intellectually by other people. But if you're sitting there alone, day after day after day, with no loved ones and no social interaction, that's got to be incredibly sad and incredibly depressing.
Well, if you allow me for 1 minute to bring a personal aspect to this particular one, I have a 91-year-old father in the island of Cyprus who lives in a nursing home, and he has pre-existing conditions. And my sister, who goes and sees him every day, they used to go and sit for 2 hours with him, talk to him, cheer him up, and this and that. And now they cannot get into the building, and she's only allowed to go for 1 minute outside the window to see him through the window and go. And you can imagine the stress and the anxiety and the depression of this, not only my father, but all the people in the nursing home who cannot see their relatives and they cannot get support for months. So these people are destined to increase their anxiety and their depression, unfortunately.
Well, another reason why I hope that your trial gets approved and that you've got a chance to test it and maybe even prove it.
Hope so, Ryan.
Well, Dr. Athelius Diamandis, laboratory and pathobiology biochemist and cancer specialist at Mount Sinai Health System, thank you for a really fascinating conversation. I've enjoyed it. I've learned a lot, and I think I'm a fan of yours now.
I'm appreciative as well for inviting me to your program.
So please stay in touch, and depending on what Health Canada and the Ethics Board say, maybe call us back and have another session with us and tell us an update.
I'll be happy to give you an update in a few months.
Thank you, sir. Good evening. That's Brian Crombie on the Brian Crombie Radio Hour, talking about clinical trials, self-infected clinical trials for COVID-19. Fascinating. Good night, everybody.